Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Peace. Welcome, YouTube. I'm your moderator and narrator, Uriel Riley. We pick up this wonderful, wonderful Saturday, the middle of page 336. Peace, YouTube. Here we go. Episode 58. For all those in the playlist and reading along, we're in the middle of page 336. Ventilator modes, figure 22.1. Definitions. Spontaneous ventilation is defined as the patient's completely controlling ventilation and providing all the necessary power, i.e., the patient is initiating and providing the power for inspiration as well as such efforts as determining the frequency and depth of tidal volume. Controlled ventilation is defined as the patient taking no physiologically significant role in the ventilatory cycle, i.e., the machine inflates inspiration, provides the power for inspiration, and determines the rate of ventilation and depth of tidal volume. In essence, whatever ventilatory efforts the patient may be making, they are of no physiologic significance to cardiopulmonary homeostasis. Augmented ventilation is defined as both the patient and machine being actively involved in physiologically significant roles directed toward maintaining ventilatory homeostasis. It must be clearly understood that the apparatus to which the patient is attached is not the sole determinant of the mode of ventilatory support. In other words, because a machine is capable of augmenting ventilation does not mean that the patient is necessarily receiving augmented ventilation. In many patients, it is difficult and somewhat arbitrary to distinguish control from augmented modes. The following clinical guideline is helpful. Tidal volume of 15 milliliters over kg or greater in conjunction with ventilator rates of 8 per minute or more are deemed control mode ventilation, or CMV. Rates of less than 8 per minute are deemed as augmented mode of ventilation if the patient is making significant efforts to breathe. If the patient is not making significant breathing efforts, even rates under 8 per minute are deemed control mode. Whatever the particular point of delineation in differentiating control from augmented modes of ventilation, the determination must be based on the patient's physiology and not the equipment's capability, right? Have to make these evaluations based on the patient that's in front of us, not on the equipment. Thank you so much for reading with us. Highest heart, love, peace, YouTube. Had a wonderful Saturday. I hope you have as well. We're in the late night and this prime time mode. Page 337. Control mode. Since the advent of intermittent mandatory ventilation, IMV, and thereby the technical capabilities of providing a physiologically sound method of augmenting ventilation, the use of control mode ventilation, CMV, has significantly decreased. However, it is our experience that the most unstable patients require at least an initial period of controlled ventilation, whereas those patients in whom the ventilatory support is required because of CNS malfunction usually need prolonged control mode. Also, CMV provides the best model upon which clinical guidelines for all positive pressure ventilation may be based. Ventilatory pattern. Inspiratory time and expiratory time may be manipulated to obtain desired physiologic effects. The relationship of inspiration to expiration, i.e., ratio, and the frequency of the ventilatory cycle constitute the ventilatory pattern. The success and adequacy of control mode ventilation are more dependent on manipulation of the ventilatory pattern than on any other single factor. Woo! That's big, right? Thank you so much, YouTube. Peace. We're pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. Thank you so much. We're in the thick of it of chapter 22. So thank you so much for reading with us. Hi, it's Heart Love. I know it's super heavy and high level vocabulary. I will put it in the description when it's finished uploading, just like the others in the playlist, so you can read along. Thank you so much for being here in the intelligent part of YouTube, peaceful part of YouTube. With control mode, IPPV, the airway pressure is lowest during expiration. See figure 22.1. It may therefore be inferred that intrathoracic pressures are lowest during expiration. Inspiratory flow rates, volumes, and time play important roles in determining mean airway pressure. However, keeping inspiratory dynamics constant, the longer the expiratory time, the lower will be the mean airway pressure. Ding! That's right. The lower the will be the mean airway pressure. Since mean airway pressure will have a direct effect on the degree of embarrassment of venous return. Relatively slow rates, less than 12 per minute, seem optimal for control mode ventilation. Large tidal volumes above 10 milliliters over kg minimize the effects of anatomic and physiologic dead space while aiding the maintenance of adequate alveolar ventilation. Tidal volumes between 10 and 20 milliliters over kg delivered in at a time span of zero point 0.5 to 1.5 seconds show minimal variations in mean inspiratory airway pressures. Incorporating large tidal volumes with slow ventilatory rates theoretically optimizes maintenance of adequate physiologic ventilation while minimizing the potential for compromising venous return. There are two additional advantages to such a ventilatory pattern. One, the incidence of military atelectasis and all atelectasis appears to be decreased when large tidal volumes are utilized. Wow. of the tidal volumes using. You see that? Atelectus appears to be decreased. There we go. We have another solution. The tidal volume, right? Thank you so much. See? Brilliance. Brilliance right here on the peaceful part of YouTube. Wow. So amazing. And two, large large tidal volumes usually are better tolerated by the conscious patient on positive pressure ventilation. There seems to be a need for the conscious patient to be aware of the ventilators expanding the chest, since when this occurs, the patient is usually more comfortable. In the absence of chronic restrictive pathology, a reasonable initial ventilator tidal volume is 15 milliliters over kg at a rate between 8 and 12 per minute, and flow rates that provide an inspiratory flow time of zero point 0.5 to 1 second. Final adjustments of the ventilatory pattern ultimately depend on blood gas analysis and other physiologic monitoring. We are in the thick of it. This is so good, right? Peace, YouTube. Thank you, all the book lovers community. Hi, it's Heart Love. Thank you so much for the likes and subs. It's a peaceful part of YouTube. Here we go. The middle of page 338. Fighting the ventilator. A patient is out of phase with the ventilator when he or she is attempting to end the inspiratory cycle by exhaling while the machine is still in inspiratory phase. What's going to happen? It's going to cancel it out, right? When a patient is out of phase, he or she is said to be fighting the ventilator. This results in greatly increased intrathoracic pressure and decreased alveolar ventilation. Fighting the ventilator cannot be justified in any mode of ventilation, with an exclamation mark. A simple method to restore control of the ventilatory pattern is to use the technique of manual ventilation. The patient's ventilation is initially augmented, and then tidal volumes are gradually increased while the rate is gradually decreased. Often, the patient will relax and eventually allow the desired ventilatory pattern to be accomplished. Faster rates and or deeper breaths may be necessary to control ventilation, assuming that venous return is not embarrassed significantly. Dead space tubing may be added to the ventilator circuit to assure eucapnic normal PCO2 ventilation. This technique will often facilitate control of the desired ventilatory pattern, but utilization of ventilatory circuit dead space tubing must be used only to control mode ventilation. Some patients will attempt to make ventilatory efforts during the expiratory phase of the ventilator. This is termed breathing around or between the ventilator and has little detrimental physiologic effect. In fact, it may be physiologically beneficial in many circumstances. It is important for the respiratory care practitioner to have clearly in mind the difference between the patient's being out of phase in distinction to simply breathing around the ventilator. In general, a patient who is out of phase with a ventilator must be manipulated to come into phase. The patient breathing around the ventilator usually may be left alone if an IMV circuit is provided. All right. Augmented modes. Between spontaneous and controlled ventilation exists the spectrum where both patient and machine play a physiologically significant role in the maintenance of the cardiopulmonary homeostasis. The physiologic advantages of spontaneous over positive pressure ventilation was introduced. The clinician has been seeking an appropriate way of augmenting ventilation, i.e., allowing the patient to do whatever spontaneous breathing he or she is capable of without detriment to homeostasis, and then having a machine augment the remainder of the ventilation. The preferred mode of supporting ventilation is augmentation. It is only when augmentation is neither possible nor desirable that control mode ventilation should be instituted. Middle of page 339, assist mode. The assist mode, see figure 22.1, has been has been available for over 30 years because of its technology was developed early in the era of modern respiratory therapy. The mechanism allows the patient to control ventilator rate, since inspiration will begin when the patient creates a subatmospheric pressure in the circuitry. Initially developed for pressure cycled ventilators, the patient had some control over tidal volumes and or flow rates. However, with the advent of volume and time cycled machines, the assist mode controls only rate. Over the past 30 years, use of assist mode has been far more attributable to its availability than to its desirability. The superficial concept that a patient is better off triggering the machine is one that holds little physiologic or clinical rationale. Yeah, that's real. It doesn't. You don't wait for them to trigger it. That's being careless and lazy. We want to stay on top of it, right? In addition to the physiologic advantages of minimizing positive pressure ventilation, true or and effective augmented ventilation also should minimize the necessity for aggressive pharmacologic intervention, such as the narcotization and paralysis, so common with control mode. Thus, for the past 30 years, there has been a constant search for a technically feasible and universally applicable method of truly augmenting ventilation. Bottom of page 339. Thank you so much for being here and reading books with us, master level books, clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, Yearbook Medical Publishers, Inc., Chicago and London, 1979. Woo, super high level vocab. Love to all the nurses, rep techs, M techs, all the OR techs. We love you so much. Special shout outs to Stephanie as well. Yes. Special shout out to all the October birthdays going on right now. Highest heart level. Intermittent mandatory ventilation, IMV. With IMV, the patient is allowed to breathe spontaneously through the ventilator circuit, and at predetermined intervals, a mandatory inspiration is provided by the ventilator. It is technically simple and universally adaptable. Figure 22.3. All gas inspired, whether spontaneous or positive pressure, has the same temperature, humidity, and oxygen concentration. The mandatory positive pressure breath takes place completely independently of the patient's own ventilatory pattern. See Figure 22.1. Since its reintroduction into clinical medicine in 1973, it has proved to be a most significant improvement in airway pressure support. Although initially introduced as a weaning technique, it has been clearly established that the greatest use for IMV is a maintenance mode. We consider our patients to be receiving IMV only when they are clinically accomplishing significant ventilation on their own. If they are receiving a ventilatory rate of 8 or more per minute with tidal volumes of 10 milliliters over kg or greater, we consider this to be control mode ventilation, despite the patient's efforts. IMV is the basic methodology by which a physiologic mode of ventilation augmented is accomplished. As such, it should be clinically defined in terms of the patient's homeostasis rather than in terms of the mechanical apparatus attached to the patient. Here we go. This is figure 22.3. And highest heart love. Thank you so much for reading with us. And it's showing how the inspiration comes out. This is schematic illustration. So only the inspiratory limb is shown while spontaneous inspiration is taking place. A represents the common gas source so that all inspired gas has the same FiO2. B represents a volume or time cycled ventilator. C represents the spontaneous breathing circuit with appropriate one-way valve. And D represents the humidifier through which all inspired gas must flow. Here you see the flow. Figure 22.3 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Thank you so much. Look at this. Moving on to page 341. Excellent as IMV has proved to be, it is not the answer for all patients. If our definition of CMV is applied, even those centers claiming no use of control mode ventilation are actually controlling at least 20% of their patients. In our experience, 80 to 85% of patients requiring ventilatory support are maintained primarily on augmented ventilation, IMV, IDV. Thus, only 15 to 20% of patients require CMV for the major portion of their ventilator course. Although many patients are on CMV for the initial 3 to 12 hours of their course, they are rapidly changed to an augmented mode following cardiovascular stabilization. We'll pause right here. No, keep going. What do you say? Yeah, let's keep going. Let's keep going. We want to keep giving to the people, uplifting the people, reading masterful books, right? Here we go. Top of page 341. Intermittent demand ventilation, IDV. Intermittent demand ventilation is a mode of augmentation in which the patient is allowed to breathe on his or her own through the ventilator circuit, and at predetermined intervals, the next spontaneous breath is assisted by the machine. See figure 22.1. Intermittent demand ventilation has been used for decades by the anesthetist who allows the patient to breathe on his or her own while augmenting every second, third, or fourth breath by compressing the anesthesia reservoir bag. Thus, an additional volume of gas is delivered in phase with the patient's efforts, i.e., on patient demand. Various techniques have been developed to provide IDV, namely synchronized IMV, SIMV, and intermittent assisted ventilation, IAV. We prefer that the term IDV be used to distinguish the physiologic concept of augmenting on demand from augmentation at mandatory intervals, IMV. At present, IDV has not been documented to be of significant advantage over IMV. IDV may prove to have significant technical disadvantages and, at best, should be considered a sophistication of IMV. The authors strongly urge the respiratory care practitioner to consider the primary mode of augmented ventilation to be intermittent mandatory ventilation and to keep an open mind as to the future application of the IDV concept. And that's where we'll pause right here. Thank you so much for reading with us. Clinical application of respiratory care. No commercial, right? On high level book readers here on YouTube, intellectual level, all the way up. When we reconvene with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout in the 22nd chapter. When we reconvene, we'll complete this 22nd chapter, have the last read. I want you to have a wonderful evening resting. I'm wishing the best for all of us. Highest heart love. Shout out to all the love and light family and friends of South LA Cafe. Opened up number 5 location today. Such a beautiful, beautiful ribbon cutting. Shouts out to the whole Slack team, right? The highest heart love to the beautiful and honorable love, Tamrell, Joe and Celia Ward Wallace, Tim, Brad, Brett, CJ, all the wonderful, wonderful light workers we involved. Mr. B and Mrs. Esther, thank you so much. Highest heart love. All of here. We did it. We did it. That's amazing. We're doing it. Healing the people and showing the way. So we want to give a big love water cheers. Shout out to all the light workers here and all around the world, shaking it up, healing the people. We uplift the people, right? When we can heal ourselves, then we can help heal others around us. That's why we read this information, right? Master thyself, and thou shalt know the whole world. Let's have a cheers to South LA Cafe, all of the staff, Slack team. We love you. So honored, so beautiful. It's what happens when you stay consistent. Cheers to all the light workers and those that volunteer wherever you are. Stand up. Power to the people. All power to the people. I love you. Love water. Cheers. Libation live. Mm. I love you. 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 Thank you so much. Thank you for reading books, all the book lovers community. Peace, YouTube. Thank you so much for all your assisting and help. Yeah, we're doing it. I told you I was going to do it. Said I was going to open up a channel on YouTube. It's going to be for mental relaxation and revitalization. And I would show people the way of peace, of love, highest heart love. And we're doing it. Look, we're pushing towards 600 subs on a channel where we read books, love on one another, right? And learn from masters. My dream come true. Highest heart love. I love you. I love you, you. I love you. You know it. I love you. I love myself. Have a wonderful day. Tomorrow is going to be another great day. We're doing a year healing session on a special year healing session on a special person. I'm looking forward to it. I'll see you in the ether. All right, we're going to the soft blue cloud this evening for rest and relaxation. I'll see you there. Peace, peace.